Good morning and welcome to the Insight APSAD webinar series. I would like to begin by acknowledging the traditional owners and custodians of the land on which this event takes place and pay my respects to elders past and present. I'm coming to you today from Meanjin on the lands of the Turrbal and Yagara people. I would also like to extend that acknowledgement to any Aboriginal and Torres Strait Islander people who are joining us today across the web. My name's Sam Clark and I'm a nurse educator at Insight, and I have the pleasure of facilitating today's webinar on access pathways for contraception in alcohol and other drugs. Our presenter today is Dr. Kelly McNamara. Kelly is an obstetrician gynaecologist and a senior lecturer at the University of Newcastle. Kelly has a special interest in substance use in pregnancy and completed her PhD at the University of Sydney, which focused on unplanned pregnancy and contraception for women with substance use disorder. We will have some time for questions following Kelly's presentation, so please type any queries that you may have or any questions into the chat, and I'll ask them on your behalf at the end. So welcome, Kelly, over to you.
Thank you, Sam, for that introduction, and thank you for having me today. I'm going to start with what we're going to cover today. So a little overview is we'll have some background about substance use disorder, unplanned pregnancy, contraception. Then I'm going to talk you through two projects that I've done. One which is a contraception pathway through alcohol and drug services, and another which is a postpartum contraception study for women with substance use disorders. We'll have a small section at the end talking about future directions, and then we will have a nice discussion about all of this. So looking at the background here, look, many of you may know this. I do always feel when I'm talking to an alcohol and drug clinician crowd that sometimes I'm speaking to the choir, so I apologise for that. But what we are looking at is women with substance use disorder and unplanned pregnancy. They have a high unmet need for contraception. And by that I mean women who have identified that they don't want to be pregnant but are not actually able to access contraception. We know women with substance use disorder have high rates of unplanned pregnancies, and in fact 75% of their pregnancies are unplanned. Many of those pregnancies are actually unwanted, and I make a differential here between an unwanted pregnancy, which we would term an absolute disaster, or an unplanned pregnancy, which is a sort of broader category, which may include many women who are actually in fact happy to be pregnant but didn't foresee this coming. If that pregnancy is unwanted, that is associated with poorer physical, mental and psychosocial health. So that's really important for our women with substance use disorder, which may already have significant challenges in those domains. What are the factors that contribute to high rates of unplanned pregnancy in women with substance use disorders? Well, like everything in this world, it's multifactorial. There's patient, social and health system factors, but some of those are things, particularly the health system factors, that we can improve. So it's important that we understand what those factors are. There is, particularly in women with opioid use disorder, a perception of infertility because they may not menstruate because of the use of the opioids. We know that that doesn't actually translate into an outcome of infertility, but it is a perception which may mean they avoid using contraception. There is and can be an ambivalence to pregnancy, and by that I mean not everybody views the world as dichotomous. We can either plan our pregnancy or we don't. There is a group of women that sit in the middle that sort of feel like, well, if it happens, it happens. Perhaps it's not out in my control anyway. And I think that is a higher group in women with substance use disorder. There are relationship factors, and we all know that there are high rates of intimate partner violence and reproductive coercion and sexual assault and sexual violence for women with substance use disorder. I have eventually landed on, after sitting with women with substance use disorder in various clinics over the years, that I don't really know how many of the pregnancies are actually the result of consensual, healthy sexual relationships. We do try and understand to some extent, but I think we perhaps don't understand just how common it is that the relationship or the intercourse was not consensual. There is sexual behaviour whilst intoxicated, and certainly there is increased risk-taking with sexual behaviour that might lead to being more likely to not use contraception and become pregnant whilst intoxicated. And there are access barriers to contraception. I make the point here that most contraception in Australia is provided by the general practitioners, who largely do a very good job. However, women with substance use disorder typically don't attend their GP, and so they don't have access to that part of the health system. So summing it all up, we find that there are cost, knowledge, stigma barriers and geographic barriers and health system barriers for women with substance use disorder. I do want to turn my attention to unplanned pregnancy rates that actually differ according to the drug used. Now, what we actually find is that there is quite a bit of diversity, and I'll show you the rates in a second. What we don't know is what the reason for that diversity is. I would surmise that it probably is the different groups of women that are using different drugs with different psychosocial factors that are making the difference. I guess an alternate hypothesis is that when you look at that intoxication, that maybe intoxication with different drugs make you more likely to conceive an unplanned pregnancy. Nonetheless, we know that in all women in the general population worldwide, 44% of all pregnancies are unplanned, which is higher than what people often realise. But we do know that essentially all of the illicit substances, and this is use, not use disorder, it's really hard to get the data the way you'd like it, all of the illicit substances actually have a higher rate of unplanned pregnancy than the general population. So we're looking up there to sort of 86% in opioids, a bit lower for marijuana. It does depend on how you use and your pattern of use. Cocaine, 63%. We simply don't have the data. I've never been able to find it for methamphetamine. Alcohol is a completely different kettle of fish, and you all know this. But alcohol is obviously the most used drug in the country, in Australia, and really, when you look at all patterns of use, which includes a large population of people, there's a lower rate of unplanned pregnancy than the general population. That said, as we increase alcohol intake, we do find there is a shift towards an increasing unplanned pregnancy rate, and those with the high alcohol intake, be it binge drinking or daily use, do have really high unplanned pregnancy rates. 3/4 of them would be unplanned. Why are we worried about alcohol and drug use in pregnancy? Look, this is always a conversation that I have tentatively, I guess, with some hesitation. I think what I've learned over the last 8 or so years is that it's really difficult to disentangle the impact of social determinants of health from the direct actions of the drug. And by that, I mean, you all know that we have, when we're looking at women with substance use disorder particularly, there is a range of socioeconomic factors that are likely to impact their pregnancy outcome. We know that women with poor mental health, exposed to domestic violence, all have poor pregnancy outcomes, or are much more likely to. And really difficult, you can't find a group of women that have really bad substance use disorder that don't have those factors. Nonetheless, we do know that there are some really clearly documented effects of alcohol use in pregnancy. Fetal alcohol spectrum disorder only occurs with exposure to alcohol. That said, there is also some diversity. You will find that for the same level of alcohol intake in pregnancy, you'll find a population that is underprivileged will have a higher rate of fetal alcohol spectrum disorder. There probably is also some genetic factors as well. We know that fetal tobacco causes fetal growth restriction, and we spend a lot of time in our antenatal services dealing with this. We know that opioids lead to neonatal withdrawal syndrome and can be associated, particularly in the setting of withdrawal, with preterm birth or low birth weight. But we do also know that if we have access to opioid treatment programs and a woman is stable in that reduces her risk, which again points to that social determinants of health. Is it really the drug action, or is it other things? And amphetamines have been associated with preeclampsia and low birth weight. Look, In terms of long-term impact, there is lots of work being done around the globe on the long-term neurodevelopmental outcomes for children who were exposed in utero to drugs. The way I read most of the data, I think it is still unclear about causality. And again, it comes back to that social determinants of health. And I'm just going to park that there. It's not the focus of this discussion today, but I just think it still needs some more time to be worked out. Now, why is unplanned pregnancy a problem? Well, it's a problem for a number of reasons. The reasons I've got listed here are all about the mum. Really, it's a missed opportunity for preconception care. We know that if we can optimise the alcohol and drug treatment before pregnancy, that the woman does better, and we're not able to do that with an unplanned pregnancy. We know that it means that there can be a delayed recognition of pregnancy, so the woman wasn't planning to become pregnant and she didn't know that she was pregnant for 8, 10, 12, 20, 25 weeks. We've all seen women like that, and during that time there is a greater exposure to drugs. Women who take drugs through pregnancy do typically try to reduce their intake or cease, and that delayed recognition means they're not able to do that. There's diminished reproductive autonomy, meaning that a woman should be able to say when she wants to try and conceive and have a baby, and she can't do that with an unplanned pregnancy, which feeds into another problem in that we still have really patchy access to abortion in this country, particularly for women from rural and remote Australia. And we know that women who are unable to access an abortion, who have unwanted pregnancies, that if they continue that pregnancy to birth, that really entrenches poverty and poor maternal health. I would also say there are implications for the baby, and we know that unplanned pregnancy is associated with low birth weight and preterm birth. So a couple of years ago, I set out to answer a question. I set out to answer, do those women who have substance use disorder, who we know already have a high risk of adverse pregnancy outcomes, if they have an unplanned pregnancy, does that further exacerbate their pregnancy and birth outcomes? And I did this through a couple of ways. I did a scoping review, which I looked at the existing data, and I found that there were really no studies published that I could find that looked at that particular question on pregnancy and birth outcomes. But we did find that women who had an unplanned pregnancy were less likely to stay in alcohol and drug treatment during pregnancy. They were more likely to continue binge drinking throughout the pregnancy and right into third trimester. And they had twice the odds of the baby entering out-of-home care by 2 years. That is unadjusted data, so I think we just need to take view that through that lens, that could be other factors at play. So following that, I did my own study where I used retrospective maternity data sets to look at this, and I found, surprisingly, to be honest, that most pregnancy and birth outcomes were not further exacerbated by unplanned pregnancy in women with substance use disorder. The outliers to that is that we found there were longer lengths of maternal stay and longer lengths of neonatal stay in the birth admission. And I suspect that might be that the women who have an unplanned pregnancy are perhaps more complex psychosocially than those with a planned pregnancy, and that those longer lengths of stay were to enable access to care for those women. We also found that in the women with substance use disorder, those with an unplanned pregnancy had reduced use of epidural anaesthesia. Now, we adjusted for all sorts of things, their number of their antenatal care visits when they first entered antenatal care, and it still persists. It was about 2/3 as likely to use an epidural. And I do wonder, again, if we're thinking that this is a more complex psychosocial group, is this representing stigma? Are they experiencing barriers on the birth unit to obtaining an epidural? And I don't have more information on that, but it's something that needs to be considered. So why do I focus on contraception? Well, as far as I'm concerned, we've demonstrated there's a high unmet need for contraception. We know that contraception prevents unplanned pregnancy. Some of our modern contraceptive methods are really good. They present, they have failure rates of 1, 2 per 1,000 women. So it's really, the technology is there. We know that it's a health and gender equity issue, that women should have access to contraception care like every other sort of healthcare. Enabling access to contraception does actually address some of those social determinants of health. So things like poverty and the ability to plan your pregnancy might actually help reduce your entrenched poverty. So it's important. Now, I do sort of say this again with some hesitation, but it is likely cost effective. And the reason I'm a bit hesitative is every time I present this, somebody sort of might suggest that perhaps I'm not wanting women to conceive a pregnancy with substance use disorder, which is not the case. But I do think it's important we talk about cost effectiveness, because it's what drives policy and what's the policymakers listen to. And I'm going to show you some data on out-of-home care, but I suspect a small contraception program, and the one I present you later cost about $20,000, is likely going to save a lot of money when you consider the cost of abortion care, pregnancy care, and the cost of out-of-home care. I'm going to diverge a little bit into out-of-home care. Many of you will know this, and it's a little bit old data. It's 2017, only because the way it's broken down is not available in the current data, but the more up-to-date numbers are just greater in terms of economic costs. So there's around about 60,000 children in out-of-home care at any point in time. We don't record in Australia the proportion with drug and alcohol involvement, but it's likely to be high. Out-of-home care costs Australia $2.7 billion per year, and $4 billion per year are spent on all child protective services, with a whopping $6.8 billion per year spent for unresolved trauma and abuse. There are also some really significant social costs of entering out-of-home care. As children enter adulthood, there's homelessness, high rates of alcohol and other drug use, overrepresentation in youth justice systems, premature death, unemployment, low educational attainment, low life satisfaction, and vulnerability to further abuse and neglect. All things that I think we could agree are probably best avoided. Moving back to contraception here, I'm just going to talk here about what we already know about what strategies increase contraception use in women with substance use disorder. So contraception counselling provided by a clinician, free contraception, case management and peer navigation, motivational interviewing. There was one project out of the United States that sought to seek behavioural change by doing small payments for the women to attend appointments. And they're very clear, it was not for them to initiate contraception, it was just to attend the appointments about contraception. Shared decision making, and in the pregnancy space, antenatal counselling, talking to that woman during pregnancy about her postpartum contraception. What do we know hasn't worked? So even though embedding contraception referrals or providing information about contraception with AOD care is more than necessarily usual care, we do know those things alone don't work. We need to actually add in some of the strategies on the previous slide. So with that knowledge, I sought to design a contraception pathway to address some of these issues, and I'm going to present that to you now. So this is the publication. There was a lot of people involved in this study. So in this study, we aimed to assess contraception use and reproductive history in women who attend alcohol and drug treatment services. And I'll go into this further, but we looked across metropolitan and regional alcohol and drug services. We then tested a rapid access pathway for contraception within the drug and alcohol service. By rapid access, I mean that they had a facilitated pathway with a fairly quick time frame to be seen. what we did, we recruited 100 women from 2 sites between 2017 and 2021. It took a bit longer than we had anticipated. As you can appreciate there, the pandemic happened in the last couple of years of the study. The women all completed a baseline questionnaire on pregnancy intention, contraception, and sexual and reproductive history. They were shown an educational video on contraception options, and this went through all contraceptive options, and it explained the benefits in terms of their health and efficacy of the contraception, also the risks and how the methods were used, how were they inserted or prescribed, how long they lasted. Everyone was then offered referral to a rapid access pathway for contraception. It was optional, so they didn't have to go down that route. The pathway was set up so that most of the contraception pathway could be done on site at the Drug and Alcohol Service. So women initially had they accepted referral, a contraception counselling appointment with an addiction medicine specialist who spoke to them on an individual basis about their contraception options, and then if they wanted particular options, most of those were able to be prescribed and inserted on site. So they could be prescribed the pill, a hormonal implant which was able to be inserted, they go on the arm, hormonal injections which were able to be given in the clinic, and we gave out some condoms as well. There were some women that were particularly complex in their contraception needs, or there were women that wanted an intrauterine device, and a pathway was set up for those to be referred externally to another provider. The outcome that we looked at was the uptake of contraception and the different types of contraception that were initiated. So to just summarise that again, the key features of our rapid access pathway were education. We educated the staff at the Drug and Alcohol Service as well as the participants. We organised referrals and we organised priority referrals. So if women needed to be seen externally, those appointments happened within 2 to 4 weeks. We facilitated those referrals. We organised the appointments so the women didn't have to call up and make the appointments themselves. The project paid for the costs of all contraception. If that was a pill, it was 12 months worth. Otherwise, if it was a device, the cost of that contraception and the cost of the insertion if they were going to an external facility that charged a fee. We also arranged that contraception for them. So we dispensed it from the clinic. So they physically got boxes of the pill, or the implant was provided, or for the intrauterine devices, we collected it for them from the pharmacy to reduce that barrier. If women wanted to be or needed transport to external appointments, that was provided through the research staff, and then we followed them up at 12 months' time. I am going to talk about some differences between the regional and metropolitan sites. This was a pragmatic study, so we worked with what we had, and there are some differences in the findings down the track, and I think it's important we understand what differences were there in the 2 sites from the outset. So we did involve consumer consultation in the pathway designed for the metropolitan site, but not for the regional site, as that wasn't available. I'm not sure that really made a difference, but we'll come back to that. Everybody, as I said, staff got educated. The counselling was provided by AOD staff. The collaborations that we set up with local sexual and reproductive health services were different. I'll put that in bold to highlight that. So the regional service, we weren't able to refer to the public gynaecology service because it was overwhelmed with referrals and they wouldn't have been able to see them in the appropriate time frame. So we set up collaborations with 3 private primary care facilities in the area. Within the Metropolitan Service, we were able to refer to the gynaecology service, and we had those appointments within 2 to 4 weeks, as we did for the regional pathway. And all of the sexual and reproductive health services were about 10 to 40 minutes drive from the AOD service. The reason there's a range is each AOD service had 2 sites, and for each of them, one was 10 minutes away and the other one was 40 minutes away. We did care navigation through this project and everybody got care navigation, but there was a difference between who was providing that care navigation. The regional site, we employed AOD nurses as research assistants, and they provided that care navigation. At the metropolitan service, we employed non-clinician researchers and women's health researchers, which is myself, and we did that care navigation. There were also some differences in the requirements of the external services. Initially, the Metropolitan Gynaecology Service wanted women who were coming for an intrauterine device insertion to have an up-to-date cervical screen. That did create a barrier because we then had to refer women to a third provider. After the recruitment of 18 women, we went back to them and we had that changed. That was never a requirement of the regional service. I'm going to start looking at the results now. These are the participant demographics. So you can see that most factors that we looked at were pretty similar. That said, the women at the Metropolitan Service were older, 37 compared to 31 years, and the women at the Regional Service were more likely to have had 2 or more abortions. And I think this is important because it indicates or suggests that perhaps those women from the regional service had a lower baseline access to contraception. I do just want to point out here the number of the likelihood that there were children in out-of-home care. So it was about half of all women, and I think I worked out how many children were in out-of-home care with all the women in the cohort, and it was about, I think it was 103. So it was an average of just over 1 per woman, which is really quite high. And you can see that of those women who'd ever been pregnant, the vast majority of those pregnancies were unplanned. It was really high. The other thing that was different was principal drug of concern. Now, opioids was most common in both sites, but as you can see here, it was very much the predominant drug of choice at the Metropolitan Service, whereas the regional service, other drugs such as cannabinoids and amphetamines were also common. We looked at the pregnancy intention, contraception and use and sexual history. So we wanted to know how many women were planning a pregnancy within 12 months, and it was very few across all sites. It was less than 10%, a little bit of difference between the regional and metropolitan setting, but overall, most women were not wanting to conceive. When we looked at those women who were not wanting to conceive, the vast majority of them had reported that they'd had sexual activity, intercourse with a man in the previous 12 months. Again, some slight differences between the sites, but most women were having intercourse. That said, only a third of women were using what we call a modern contraceptive method, so condoms, pills, injections, hormones, intrauterine devices, sterilisation. And I've got another slide on this later to show you in graphical ways. But basically, overall, what this means is that there was really a high proportion of women in this study that were at risk of unplanned pregnancy. By that I mean they were not planning a pregnancy, but they were having intercourse and they weren't really using reliable contraception. We asked women what their reasons for not using contraception if they didn't want to conceive, and the most common reason given was they weren't sexually active, but there was an incongruence in that response in that 2/3 of women who gave that response had actually earlier on the questionnaire indicated that they'd had intercourse in the past 12 months. I don't have the reason for that incongruence. I could surmise that it might be a here and now effect. Right today, I'm not planning on being sexually active, but perhaps intoxication gets in the way. Perhaps there's an issue around sexual consent and sexual assault and reproductive coercion. The other sort of key thing that was brought up was this ambivalence to pregnancy or contraception that I mentioned earlier. Seemed to be quite common. Okay. Moving over to the results of the rapid access pathway, what actually happened when we provided women access to contraception. So in women not planning to conceive, we had 1/4 of those initiate contraception through the pathway. That said, there were enormous differences between the sites here, and you can see almost all of the contraception initiation happened in the regional site, with only one woman initiating contraception in the metropolitan site. We looked at the methods of initiation or contraception. So, to our surprise, most women initiated an intrauterine device, and although nobody did from the metropolitan site, it was still the most common form of contraception requested. We had 5 or 6 women from the metropolitan site who requested an intrauterine device, and for a range of reasons it didn't ever get inserted. There were some women who took up more than one method of contraception, but usually that was a stopgap. I've got to wait 2 weeks or 4 weeks for my IUD appointment. This really is just talking through what happened through the pathway, trying to troubleshoot where, in fact, are the differences. Was there one point in the pathway that maybe we can see there was a problem with the metropolitan site, or maybe one point in the pathway where the regional site weren't able to provide more contraception, but really it wasn't able to answer the question. What we're seeing here is that every point of the way, so how many women were intending to conceive, then how many women accepted a contraception counselling, how many women then requested contraception, and then ultimately how many received the contraception. At every point in that journey, less women continued through the pathway at the metropolitan service than the regional service. Here I am showing you the before and after, so the different types of contraception that women were using. And this is just in women who are not wanting to conceive, as is all of this data. And so probably the most striking thing here is that you can see over here on the right, really before and after, overwhelmingly, in women not wanting to conceive, most women weren't using any contraception at all, which is still a problem. But what you can see if you move over to the left-hand side of the screen, that throughout the pathway, now we've got grey as baseline, the diagonal blue stripes is immediately after the intervention, and then the horizontal blue stripes is 12 months later. So you can see that these most effective forms of contraception, intrauterine devices, implants, sterilisation, became more commonly used throughout the pathway, and these less effective types, condoms, natural methods, and even none, dropped off. So that does seem to be an improved access to contraception for women who are attending alcohol and drug treatment services. Those of us in the study did sort of sit down and try and work out what were the possible facilitators and barriers. We haven't formally examined this, it does need to be worked out. And we think there are some internal and external factors to the study. So I do think that the regional site had a population that probably had a higher unmet need for contraception, so then providing them a service that they hadn't been able to access meant they were more likely to initiate. The contraception information came from a trusted source. That was sort of common across the 2 sites, but we did probably have a predominance of a clinical champion at the regional centre, and the care navigation that was provided at the regional centre by the AOD nurses, I think, was done really well. And I think that it's very clear to me that the AOD nurses kind of had a really good idea of what these women needed to help navigate through the program, and perhaps those of us who were at the metropolitan site, myself included, did our best, but perhaps because it's not our scope of practice, that we weren't quite able to meet the needs of women quite as well. There was a project concurrently happening at the regional service that was testing a pregnancy intention screening tool. It was sort of a coincidence that that was happening, but I think it did mean that contraception was on everybody's mind in terms of the clinicians more, and that was able to identify, was identifying women with an unmet need for contraception, and then that sort of meant that they were able to be referred to our study, even though that wasn't the design of either the study. Some barriers that we experienced, I think we wondered if the referral pathway of referring women to the gynaecology service in a hospital where maybe they'd had their baby and perhaps they'd had their baby assumed into care could be re-traumatizing and meant that women didn't want to actually go through with that. And we worried about the real and perceived stigma of accessing those services. Some things that I don't think necessarily made a difference between the studies but do need to be considered is how we do intra-hospital referrals and how that relates to Medicare billing and activity-based funding, what space is actually available in the AOD services. My observation as an external person is there's usually very little spare room for someone extra to sit, what equipment available and what skill sets might be available. We do also need to think about transport and costs of contraception and appointments. We'll come back to that study at the end and just talk about lessons learned, but just for the moment, I'm going to move on to another study, which is on postpartum contraception. This study looked at postpartum contraception in the birth admission. It wasn't an intervention study. It is really looking at what the current situation is and so what lessons we can learn. We know women with substance use disorder typically don't attend the 6-week postpartum appointment with the GP. Now, core business at that appointment is a contraception discussion, so they're missing out on that aspect of care. We also know for alcohol, and this data is just simply not available for other drugs, but women who drink alcohol in pregnancy have 12 times the odds ratio of a short birth interval, so conceiving a pregnancy relatively quickly. And we know that short birth intervals, particularly if there's sort of less than 6 months between birth and conceiving another pregnancy, is associated with adverse pregnancy and birth outcomes such as stillbirth, preterm birth. So it is important. In this study, we aimed to describe the prevalence of substance use disorder in pregnant women, and we wanted to do that because it's not well understood in Australia. We then compared women with and without substance use disorder and their initiation of postpartum contraception during the birth admission, where they're in a unit with obstetrics and gynaecology expertise that can provide that, and which method of contraception they were interested in. We did this in one local health district in New South Wales, so it may not be applicable elsewhere. We defined substance use disorder in terms of what was available in the data set, which was current engagement or need for engagement, i.e. a referral with the alcohol and drug treatment services. Our study outcomes were contraception initiation during the admission, and then the most effective method of contraception that women were interested in. Women often expressed interest in more than one method, but we picked that most effective method. So between 2011 and 2019, there was around about 60,000 women in our cohort who had slightly more babies than that because of twins and triplets. In that cohort, there were 429 women that were identified as having a substance use disorder, which gave a rate of 0.7%. That rate is comparable to other unpublished data I have from other New South Wales local health districts using a different style of database. And it is also comparable to pre-existing research on substance use disorder using other types of maternity data sets or other existing data sets in Australia. But we know that the rate of substance use disorder in Australian women, not necessarily broken down by age, but in Australian women is actually higher than that, it's 2.1%. And so there is a gap there, quite significantly, which I think probably represents that we're not identifying all the women with substance use disorder in pregnancy. When we move on to contraception, here over on the left, we're looking at all women with contraception. So 50% of all women had no contraception plan documented in the database by discharge. It was roughly the same in the two groups. Now, we don't know if no documented plan means there was no plan or just that nobody wrote it down. But nonetheless, postpartum contraception and a discussion of the options is a core part of the postpartum check. And so that was really quite quite striking that most women, or at least half of women, are not receiving that, or at least having it recorded. When we looked at the number of women that started or initiated contraception, and by that I meant that they had an intrauterine device put in, they had an injection given, they had an implant actually inserted, or they went home with a box of pills, because I didn't include people just going home with a script, because you wouldn't actually know if they started it. But of those women with substance use disorder, 12.5% initiated contraception during the admission. And initially I thought that was quite low, but then I looked at the women that didn't have a substance use disorder and found that was only 1.4%. So it's low for everybody, but it's actually a little bit, quite significantly higher for women who have a substance use disorder. The adjusted odds ratio, which I haven't presented here, was around about 6. It is also important to point out that this rate of 12.5% has been demonstrated elsewhere in New South Wales in an audit of postpartum contraception. It was consistent with that. We move on to the types of contraception that women were interested in after they'd had their baby. And you can see here the light blue is women with substance use disorder, the darker blue is those without. And much like the earlier study, we're seeing that women with substance use disorder more commonly wanting or interested in the more effective methods here. I've grouped them: intrauterine devices, implants, and sterilisation. And that was really quite low in the women without substance use disorder. Still, overall, most women didn't express an interest in anything, and you can see that on the right-hand side. So what are the lessons that we've learned from what I've presented today? So going back to the first project, contraception pathways in alcohol and drug services, we've demonstrated that there is a high unmet need for contraception in women who attend drug and alcohol services. The women that most commonly requested intrauterine devices, that was a surprise finding for me. We were very much set up to easily provide other options, but I think we do need to think about that in future studies. That rapid access pathways for contraception result in increased uptake in some settings, but probably provision of access to contraception alone is inadequate to improve access, and that's consistent with the background information, that we need to do more than just saying we can give you some contraception if you'd like it. We need to think about those care navigators and the clinical champions in getting the projects up and running. When we move over to the postpartum study, what we can say on the basis of this is, I alluded to this before, that maternity data sets likely underreport substance use disorder, but actually go one step further in that I think probably the reason why maternity data sets underreport substance use disorder is that who work in maternity are not ascertaining properly who has a substance use disorder. That might be because it's not disclosed. It might be because we're not asking the right questions in the right way at the right time. Again, that needs more work. Overall, contraception initiation during the birth admission is low for everybody. Most women are not starting contraception during that admission, but that more than 5-fold greater initiation in women with substance use disorder does suggest that perhaps we've optimised it as much as we can in women with substance use disorder, considering the background environment, that this is actually just not being done very much at all. It is important to remember that women with substance use disorder don't usually attend that GP postpartum check, so we need to think about alternate access pathways to contraception. They're not getting it in the birth admission, they're not going to get it with the GP. So where else can we think of doing that? What opportunities beyond the birth admission can we think of providing access? And because women expressed an interest or a keenness for the more reliable methods, it's important that they have access to those methods, the methods that they would like, and that we develop pathways that can provide that. In terms of the future work, at the moment I'm doing the first study, so I am interviewing healthcare workers, so AOD clinicians and maternity clinicians, on what their perspectives of the healthcare barriers, health system barriers to providing contraception, to accessing contraception for women with substance use disorder. I think we need to consider wider implementation of contraception pathways through alcohol and drug treatment services, but making sure that when we do that, we take on the lessons learned and develop those pathways in ways that will be useful. Screening tools for pregnancy and alcohol and drug treatment services. Now, this hasn't been the focus of today, but I think it's an important point. How do we know if a woman needs contraception if we're not actually asking her, does she want to have a baby? Is she using contraception? And I think there is some talk in New South Wales, at least about introducing screening tools, but it is an important concept to think about. And finally, I think it's probably time to look at alternate settings to providing postpartum contraception pathways for women with substance use disorder, given what we're doing at the moment isn't providing access to most people. Should we be looking through child and family health services, mother baby rehab centres? Should we be providing this through the substance use and pregnancy services? And finally, I'd just like to thank all the funders and all my collaborators that have been involved in this study, and the 2 local health districts who I've chosen not to name, but who did provide funding and grants for the contraception study. And now I will turn over to the audience for questions.
Thank you very much, Kelly. That was such a very in-depth and very detailed presentation, and probably a lot of things to think about. We've got a few questions in the chat, so I will try to get through as many of those that I can. So one says, are you aware of any training available for nurses to upskill their knowledge on contraception and how to deliver this to young people?
There's nothing, to my knowledge, that's specific for nurses who work in an AOD space, but look, at least I'm from New South Wales, Family Planning New South Wales run courses for nurses, they do, where they can get upskilled in that. And there are a number of clinicians that I'm aware of, AOD clinicians, nurses and addiction medicine specialists who have done training through Family Planning New South Wales and are then able to actually provide that care. So that is one avenue, and there is usually a family planning service in each state. So there are other organisations that you could approach.
I suppose that kind of leads on to one of the other questions, which was a bit of a reflection to saying that there were those higher rates of acceptance of contraception in the regional areas. And you touched on that you thought that the relationship aspect between the clinicians and the women may have helped with that increase. So I suppose, given that the question is, is there that training for nurses, do you think that there should be potentially some more further input into training AOD nurses in particular to be able to deliver that intervention?
Look, I do, but I'm going to, be completely honest. I'm a maternity clinician or an obstetrician gynaecologist. What I've learned over the 8 years that I've been doing this work now, that I probably didn't understand at the beginning, is that there are many competing priorities for AOD nurses, AOD clinicians. So in an ideal world, I think it would be great if there was a body of workforce in every AOD service that could do this, but at what cost and what are they not going to do if they're going to pick up this? And I think that's where a lot of these implementation projects really have challenges, is around workforce capacity.
Yeah, and that leads on to one of the other questions that said, would the co-location of midwives within an AOD service for, say, 1 day a week help with increased contraception and pre- and postnatal care?
I don't know the answer to that. It'd be interesting to look at. My observation is that contraception isn't probably done that well in maternity settings either, in a postpartum sense. And there are certainly some wonderful midwives that are having these conversations, but like the AOD nurses. Everybody's got competing priorities, and we absolutely know that antenatal counselling, so talking to women about contraception options during pregnancy, whoever can provide that, has been demonstrated to increase initiation of postpartum contraception. But again, at what cost? What are they not going to do? And where do you get that workforce from? So I think, anything that is designed needs to be taken with all of that on board to make sure that people have capacity to do the work we ask them to.
Yeah, I suppose I was thinking about you mentioned the drop off of people attending that 6-week postpartum check, and that would be the point that you would look to initiate, or have that discussion about further contraception at that point. That if there was that co-location, that potentially could improve that attendance. It's an environment the women are familiar with. You've potentially got the ability to have that conversation, get that postpartum check, and have that contraceptive discussion then.
Yeah, absolutely. That would be certainly one option. We were very lucky at the regional site. The AOD nurse that did most of the navigating that we employed as a research assistant was in fact a nurse and a midwife. And I think actually the success at that site really comes down to her expertise and her ability to navigate through this, because she came with that pre-existing understanding, but also of contraception, but also that ability to sort of navigate her patients through the pathway. So yeah, very possibly co-location of a midwife. I know there are some midwives being employed in sub-services in New South Wales. I don't know about other states. We do also need to make sure that those midwives would have the training. Not all can actually, not all midwives feel confident to have these discussions, and certainly not all are trained to do some of the contraception provision as well. But yeah, it's definitely an interesting space.
Absolutely. And there was a comment for somebody to say that they want to implement some of your research through their local health district into their subs team, and also commented that some of their AOD services do have registered nurses, registered midwives working in the substance use and pregnancy and parenting. Yeah, so it's great
they
that
do.
some areas do have that, but again, reflecting on what you said about those differences between metropolitan and remote, there's differences between states.
Yeah, I think there are differences between states, and the other thing to sort of remember is there still needs to be a pathway. Probably the surprising finding for me was this interest in intrauterine devices, and so we counselled women sort of in a non-directional way, and that's overwhelmingly. And I sat with, I did a substantial amount of the recruiting myself, and time again, I heard women would watch the video and say, "Oh, that Marina, that looks awesome," and so there are nurses that insert intrauterine devices. There are, but largely that's not the bulk of the nursing workforce, the midwifery workforce. So we would still need to have in place, a pathway for them to be able to access their chosen method. But for anybody who's wanting to implement any of this, I'm very happy to get an email. I'll be in contact to try and help you, on a deeper understanding of the challenges that we have at certain times.
That's wonderful. Thank you very much for that offer. I'm sure that you will get some people who will contact you on the details on the screen to ask for some further support and advice. Just going back to something that you mentioned quite early in the presentation about the rates of unplanned pregnancies. Is Australia in line with other countries across the world with the rates of unplanned pregnancies, or is the cost associated with contraception a prohibitive factor?
Yeah, look, the rate of unplanned pregnancy does vary. We probably have a slightly lower rate than I've provided global data there. I think the Australian rate is a little bit below 44%. Look, a bigger discussion than what people realise, how this data is collected, how accurate it is, what's meant by an unplanned pregnancy. It's all kind of quite complicated, to be honest. But yeah, we probably do sit somewhere just slightly better than the global average.
I have a question saying, are the intrauterine devices popular in the regions because of a lack of remote area health resources?
It wasn't a remote setting, I might add. It was a regional area that was not too far from a metropolitan setting. I suspect it's worse in the access is much worse in the sort of more remote areas. There's probably a paucity of services around, although there was some. It's a low socioeconomic region, so I think that the services that were available were not necessarily accessible by women in our study as well, and they were often paid services. I think that answers the question. Does it?
I think it does. You mentioned as well about the lower rates of uptake of epidurals in women who use alcohol and other drugs. Do you think, or did you gather anything from the data that might have indicated that there was a reluctance for the women who use substances to ask for medications?
We don't have that sort of qualitative data. So all I really have is a rate it came from a large maternity data set. But I've worked on labour wards for a while now, and I don't think that's probably the reason. I'm really concerned that it's more of an access issue and that they're not being offered epidurals where other people are. I can't really prove that, but there are qualitative data from other settings, the United Kingdom, of women with substance use disorder who do very clearly report stigma around intrapartum anaesthesia and report being denied epidurals.
Yeah.
And that would be consistent with my feeling as a clinician, sadly.
Thanks for that answer, Kelly. How can we as healthcare providers support pregnant individuals with substance use disorders more?
Well, that's a great question. If anyone comes up with the great answer, then I'm all in. But look, I think that the work that the substance use disorders, the subs teams are doing around the place, as I said, I'm most familiar with New South Wales, but we've had a quite significant increase in resourcing in the last few years. And certainly the subs teams I'm involved with now have social workers, midwives, child and family health nurses, and I think that's all very helpful. From a maternity perspective, I really think these are the women that would benefit most from midwifery continuity models where they get to see the known midwife throughout pregnancy and, if possible, at birth, where we can make plans during pregnancy for things like epidurals. We can have those discussions. I also think, and there is absolutely no guidance on this whatsoever, but I also think that all women with substance use disorder need some oversight from an obstetrician. Terrible health outcomes and pregnancy and birth outcomes. Really interesting, none of the guidelines sort of globally really touch on obstetric care. If you go and read all the substance use disorder guidelines, they talk about the psychosocial response, the AOD response, referral pathways, but nobody's actually sort of putting it together like these women have increased risk of stillbirth, and when should we be actually delivering them, when should we be doing ultrasound surveillance. None of that's actually in any literature. So I think there is a lot of work that we can do from my side on maternity as well.
Well, that's really interesting. Obviously, coming from an AOD and mental health perspective, as you say, it's not something that I personally would have looked into in that detail to see those gaps. So yeah, definitely some work to be done across the board to improve that. We've got lots of thank yous and fantastic work and very informative comments in the chat. It's been a very well received presentation. So I'd like to thank you again for providing us with the insights, the information, and your technical expertise, and wrap up the webinar for this week. So if you're still online, please join us next week on the 28th of May, when we'll have John Kelly and Cassie Davis, who are presenting recommendations from LGBTIQA+ people to improve alcohol and other drug treatment services. And please, if you have time, don't forget to fill out the post-webinar survey. We'd love to hear your feedback and suggestions on what we can do for future webinars. So thank you very much, and see you next week. And thanks again, Kelly.
No, thanks for having me.